Dr. Campbell and I came up with this to talk about this topic. One of the first questions we had is, are we talking about people with opioid use disorder or chronic pain? You can go to the next slide, because that really, the approach to those different populations is very different. And what we decided to do is focus on those with opioid use disorder today, and then in November, we'll circle back to chronic pain. So go ahead, next slide. So just so everyone's on the same page, so the treatment for opioid use disorder in pregnant and postpartum women is ideally a comprehensive integrated care program where you're providing prenatal care and postnatal care with obstetric providers, as well as alongside with addiction specialists that can deliver medications for opioid use disorder, relapse prevention therapy, address comorbid mental health problems, trauma, and psychosocial needs. Next slide. This is a really fantastic resource if you needed to know anything about management of opioid use disorder during pregnancy and postpartum. I will leave that for if you ever need it. We're going to just pull out the medication piece of this. So next slide. From SAMHSA, so SAMHSA is the Substance Abuse Mental Health Service Administration, who basically recommends that buprenorphine and methadone are the safest medications to use in a pregnant woman with opioid use disorder, and we are to not taper these medications during pregnancy. Next slide. So in fact, every organization, professional organization that has a hand in women's health or addiction all recommend that the standard of care is what I just mentioned in terms of that comprehensive component, but the medications is a critical part of that care, and that includes methadone or buprenorphine. And so you would think that we could just kind of stop there and that would be the end of it. But I think there's two really critical components of this. One is why. Why is it that we are making this recommendation when we know that there are risks associated with methadone and buprenorphine? So I want to hopefully make that really clear to folks today why we're doing this. And then the second part is that, although, we make these recommendations and it's based on what the best evidence we have to date, a lot of times patients aren't going to follow our recommendations nor want to, which is completely understandable. So how do we actually approach that when that happens in this particular case? So we spent a lot of time looking at the literature around, can we taper methadone or buprenorphine during pregnancy? And this kind of story dates back to the 1970s. There were some really influential case reports and then one very large, 100 people retrospective cohort study that seemed to suggest if you tapered a pregnant woman off of methadone in pregnancy, that she was at risk for these really bad obstetric outcomes, including things like preterm birth and stillbirth and meconium in the amniotic fluid, et cetera. And it made people really concerned about doing that. And so you'll still hear a little bit of that today, that you shouldn't be tapering these medications because of the obstetric risk. However, what was not really picked up in the literature until the 1990s and then subsequently was that a lot of these women that were tapering these medications in pregnancy were relapsing to drug use. So in some studies, upwards towards 50 to 90% or 70% of people, were relapsing to substance use. And so it called into question, are the obstetric outcomes that are happening here really because we're tapering a medication or pregnancy, or is it because people are relapsing to substance use and all the kind of sequelae and consequences of that? And maybe that is what's contributing to these poor obstetric outcomes. So in a couple groups have reviewed this whole literature, and as you can see, when women are tapered from methadone or buprenorphine in pregnancy, the risk of relapse is quite high, but also really variable. And that variability has a lot to do with the fact of different treatment settings. So if a woman is tapering this medication in the context of a very high level of care, whether that's a residential treatment facility or inpatient for months, intensive outpatient treatment for months, those people tend to be a little bit more successful in tapering off these medications and not relapsing. However, that's a pretty rare group of people, and the vast majority of the studies here basically show that the risk of relapse in tapering these medications are quite high. So next slide. So as you all know, when you're having conversations with women about medications in pregnancy, we kind of have this risk-risk discussion. And so we talk about the risks and the potential benefits of the medication. So for medications with opioid use disorder, we have risks of preterm birth, low birth weight, either neonatal abstinence syndrome or newborn opioid withdrawal syndrome, which is quite common and costly. There's issues with access to care and just a wish to not be on these medications. So we're essentially weighing those risks of the medications against the risks of not being on these medications. And in this case, the risk of not being on the medication is a risk of relapse. And everything that comes with relapse, which is, if we're talking about IV heroin, we're talking about really rapid cycles of intoxication and withdrawal, risk of infections, high risk behaviors, puts women in a whole host of bad situations and poor obstetric outcomes. So the literature that I'm referring to in those professional organizations, where they've really come down on this is that they've said, yes, we know that there are risks associated with methadone and buprenorphine in pregnancy, but we're willing to accept those risks because we know the risk of relapse, meaning not being on these medications, is so high, and the consequences of that are very severe. So that is where kind of the field has landed. So next slide. So now we get down to clinical practice. And in clinical practice, you know, women are coming in saying, yeah, I know I'm supposed to be on this medication. I know it's recommended, but I don't want to be on this medication, and for various reasons. And, you know, I was seeing this over and over again, and I was kind of having this risk discussion over and over again, and felt like oftentimes the information that was presented to women around this decision was not balanced. Women didn't have the full picture of the risks of the medications. They didn't have the full picture of the risk of relapse. So we created a shared decision-making tool. There's kind of like international standard how to create these tools. There's actually a lot of them in OBGYN for things like VBACs and things like that, where essentially you're just sharing that information with people. You're going through that risk discussion in a more systematic way in terms of looking at the literature, but then you're applying that information to that individual. And so that's what this shared decision-making tool does. And when we did this, we sampled this, we used this in about 25 women and kind of got their feedback. What was really impressive is that at the end of this process, in that one session, 95% of women who were originally ambivalent about continuing or discontinuing this medication had made a decision and were ready to either, 2/3 of them wanted to stay on, 1/3 of them wanted to taper. So instead of kind of punting the decision, which often happens a lot of times, and then you're all of a sudden at 36 weeks pregnant and the person wants to taper, this is something that this helps just to kind of move that process along, make a decision so you can implement treatment. Women really liked this tool. The feedback was really positive. So next slide. So I'm going to go through this shared decision-making tool in the case that we have today. So we can go to the next slide just for the sake of time. I do want to mention two things because they relate to tapering, which is kind of dosing of buprenorphine. So we first started using methadone in the 1970s. We have tons of data on methadone in pregnancy and how at a stable dose, how the level of that drug in someone's blood changes over the course of pregnancy, which is it will go down if the dose stays the same, meaning the level in the blood. And so there's pretty standard protocols in terms of increasing methadone in pregnancy. Again, it should be in response to cravings, but it's pretty clear that you're going to need to increase that dose as someone moves along in pregnancy. Buprenorphine, we've really only been using for the past 10 years in pregnancy. And so it's not until relatively recently that we really have some decent data that looks at the pharmacokinetics and dynamics of this drug. And it seems to suggest that, that as you move along in pregnancy, when someone's on buprenorphine, you are likely going to need to increase the dose because their levels are decreasing in response to just the normal physiological changes in pregnancy. So, you know, in people that are trying to taper, you know, they might get down to 8 milligrams and then all of a sudden it's not holding them anymore. And even people that want to stay on, they're at 16 milligrams and all of a sudden it's not working anymore. And so it's really important to just emphasize with women that, you know, this could potentially change as we move along. We might need to up the dose or even split the dose. Sometimes just taking the dose and putting it at multiple times during the day can be helpful. So next slide. The other issue that comes up all the time, and this was borne out in the methadone literature for a long time, was as you would think that the dose of the medication would equate to higher dose, higher risk of NAS. For methadone, that's been shown to not be true. There are so many other factors that seem to so many other factors that are kind of in the etiology of NAS, and a lot of them that we don't know. But dose does not seem to be a predictor of whether a baby is going to have NAS or not. And we're seeing that now in the buprenorphine literature, where higher doses are not predicting NAS or even more severity of NAS. So those are things that will just come up a lot when you are trying to taper someone, where they will say, you know, I don't want to go back up because the dose is going to predict NAS, and that's just not true from the literature that we have so far. So that's where I'll stop the didactic and yeah, so we can have some time for the case presentation and questions.
Okay. Well, thank you so much. And 1 second, Dr. Gill.